Good morning, everyone. Please go ahead and take a seat if you're still standing. There's plenty of room up front if anybody wants to move forward. Thank you all for coming to our workshop today on newborn screening. We'll be talking about the new horizons in CF newborn screening, advancements and updates with a focus on implementation of the guidelines. I'm Rachel Linneman. I'm a pediatric pulmonologist at Children's Healthcare of Atlanta and Emory University. And my co-chair, Marcy Sontag. Oh, is the microphone not working or is it just not? It's on. Okay. Is that better? I need to be closer to the microphone. Can you hear me now in the back? Better? Still not great? Okay. You have to be very close to the microphone. I'm Rachel Linneman. I'm a pediatric pulmonologist at Children's Healthcare of Atlanta and Emory University. And my co-chair is Marcy Sontag, who's the director of the Center for Public Health Innovation. These are our disclosures. And here's our program today. First, we're going to have Dr. Ariel Berlinski discuss a quality improvement project focusing on reducing the age of first event for infants with positive CF newborn screening in Arkansas. Then we'll have Dr. Clement Wren discuss CF newborn screening notification practices and how those may be associated with time to evaluation. We'll have Dr. Caitlin Krivchenya from Nationwide Children's talk about the Ohio CF Newborn Screening Collaborative with a focus on decision-making around implementation of next-gen sequencing. We'll have Dr. Mel Collins from Connecticut's Children's talk about longitudinal evaluation of the Connecticut Newborn Screening Program, again with a focus on their experience with implementation of next-gen sequencing. And finally, we'll conclude with Dr. Marcy Sontag talking about policy and finance considerations when adopting next-gen sequencing. Each presentation will be about 15 minutes, followed by about 8 minutes of questions and answers. You can ask questions at the microphones in the aisles, or you can submit them in the app, and we'll read them out. And with that, I'm going to have Marcy introduce our first speaker.
We have thank you. Thank you so much, Rachel. And I'm excited to be able to introduce Dr. Ariel Berlinski. Dr. Berlinski is a pediatric pulmonologist at Arkansas Children's Hospital and professor of pediatrics at the University of Arkansas for Medical Sciences. Dr. Berlinski.
Okay, you always worry about tripping on your way up to the podium, but it's a good start. That have not. So as it was just introduced, I'll be speaking on behalf of our team on a quality improvement project that we just worked on, titled Reducing the Age at First Event in Infants with a Positive Cystic Fibrosis Newborn Screening in Arkansas, a Quality Improvement Initiative. These are just co-authors of this work, and I get to speak, but wouldn't have done it without them. These are my disclosures, but actually none apply to this work. Okay, a little bit of background. So we are the only accredited cystic fibrosis center in the state of Arkansas, and about 17 years ago, July of 2008, we started doing CF newborn screening. And historically, the health department was responsible for follow-up once the second tier test was positive. And we are an IRT DNA test state. And they were communicating with the PCPs and then working with us in coordinating for sweat testing or evaluation. The person who was doing that retired, so that sort of created an opportunity, and those responsibilities were actually transferred to the pediatric CF center. Around the same time, we took the opportunity to participate in a collaborative, the newborn screening collaborative, and that helped us, I would say, strengthen our work with the health department. So when it was time to choose our QI work, we sort of look at the literature and a little bit of our data 2, as I'll show in a minute. But we all know that timely evaluation of infants with a positive newborn screening, it is critical because it affects clinical outcomes. So that's, we all know. And we know about the recommendation of seeing these patients within the first month of life. So we decided to focus our effort on reducing the age at first event, and we defined that as the first time these infants were seen at the hospital for either a sweat test and or a pulmonary evaluation. And these were for infants who were positive for newborn screening for CF. And this is, they had 1 or 2 DNA mutations on a 60 panel mutations. This QI work was deemed not to be human research by our local IRB. So we started participating in the collaborative meetings, but also we met individually among ourselves on different occasions. In a way, for us was, I would say, just a learning experience, because we ended up having to flow map new processes and redesign it. We look at the fishbone, we started some PDSA cycles, and interesting enough, we had the opportunity to visit the newborn screening laboratory, and they show us how the magic happens. And it was just illuminating for us, because we did not know that some of the limitations on frequency are actually because of space, personnel, things that cannot be changed in the current environment. So I think that also helped us. We designed a flow map, and I don't expect you to read the flow map, but I want to just call your attention that there are different colors that those represent who has to do what. And I think that was one of the important things that we did. We clearly assigned certain duties to certain people, both at the Children's Hospital and at the Arkansas Department of Health. We created a fishbone in trying to see what were the things that will contribute to the age at first event. And those themes, the 6 themes we identified, one was the CF Center, the other one was the Arkansas Department of Health, third one was the communication, fourth one was the birth center, then the process itself, and finally also just the family that had a child with a positive screen. Anecdotally, we have heard that it was difficult sometimes to get a hold of the pediatrician and get the referral in a timely fashion. So we also looked at what we can do and what things we can affect. And we decided to include only patients that were ambulatory, but none who were hospitalized, born out of state, deceased, that had a second tier, maybe because they're a sibling of a child with CF. Some have moved out of state. Some had duplicate testing because they were maybe newborns or done with less than 24 hours. There are some parents that refuse the testing, and we had some infants that were lost to follow-up. We had 2 PDSA cycles. The first one started in July of 2023, and that included identifying the stakeholders, both at the Department of Health and Arkansas Children's. As I said, we toured their laboratory. We reviewed our baseline data that I will present soon, that had included July of 22 to June of 2023. We created a fishbone. We developed flow maps, but also we had tracking tools, communication tools, EMR documentation, really in trying to standardize and having sort of an SOP, internal SOP of how to do things. We trained our members, and we created an urgent scheduling policy that would allow us that if we do not receive a referral within 48 hours of requesting, we could call the family. And that in a way breaks with some of the mantra of having the pediatrician call them, but we thought that that will help us reduce the delay in referral. We piloted those processes. We got some feedback from both the Department of Health and the children's, the different team members who were in charge. The second PDSA cycle was July 2024 to June 2025. And then we made some changes of things that we sort of learned during our participation in the Newborn Screening Collaborative, like delaying sweat tests for patients who were homozygous for 508. But we just brought them in right away. We implemented also some EPIC chat to improve our communication, and we adjusted our intake assessment. And I think that this is very important because the nurse or nurse scheduler who is contacting the family is looking at how the child is doing. So it's really very personalized. Have they regained their weight after 2 weeks, if they're around that? What's the status? How are they feeding? What are their stools look like? And then if they meet the criteria to bring them in right away, we will then schedule a sweat test and give the information. And we tried to kind of balance the need for bringing them soon with also the risk of having a QNS sweat test. I think it's a very fine line, but we sort of did an active monitoring of weight and growth and work collaboratively with the pediatricians. So these are results from our work. On the FY23 was sort of the baseline year, and then we have the other two PDSA cycles. We had 51, 27, and 31 eligible infants for these. The age at the initial IRT was 3 days. The median on all this data is median and interquartile range. So that did not change over time, and we probably don't expect that will be. And having that done at a median of 3 days, we thought it was good. We also looked at the age, the DNA results when we got the notification. And in 2023, it was a median of 14 days, kind of about the same for 24. But you could see that in 25, that actually was reduced to 11. So when looking at the percent of referrals for PCPs, in the FY23, we have about 100. On 24, we had 85%. And in FY25, we had 94%. However, what's probably even more important than that is the fact that the time from the day the newborn screening results were sent to the PCP to the actual referral received significantly improved over time. And you can see that the baseline data has a median of 15 days that was reduced to 5 days in 24 and then to 3 days, a median of 3 days in 25. An urgent scheduling policy, and when we are just talking about this project, I would have bet money that this was going to be the game changer for our problem. And yes, we used it 54% of the times in 24, but only 13% of the times in 25. And I'll just, I think that this reflects that the team was working better, that they were doing things repeatedly, and they got better at doing that. This is our annual data, and you could see that our baseline on FY23 was 39 days. 24, it was reduced to 22 days, and for 25, we are at 19 days. One thing that you could see on the graph on the right-hand side is that while there is no statistical difference between FY24 and 25, the dispersion of the values is lower. And I think that we have probably a more controlled and tighter run process. This is the same data, but in quartiles. And you could see, again, on the right-hand side, on the green dots, those are the last year, really with less variation than the previous year, that while the differences are not significant, I think the system was working better. This is outcomes of our CF newborn screening for FY 23, 24, and 25. Not that anything of what we did had anything to do with this, but we had the same amount of patients with CF and CRMS in 23 and 24, and kind of the reverse happened in 25. So what did we learn? So number one is that applying QI methodology and working in partnership with the health department and ACH Center, we were able to decrease the age of first event of infants with positive CF newborn screening from 33 to 19 days. I think it was also important to talk about the importance of measuring the different components that lead you to that time. So then you can say, well, if the IRT is done at 3 days of life, well, it's not going to get any better, and probably we should not be working on that, and they kind of move on to see if there are other things. For example, we learned that currently they cannot do twice a week DNA. So then the delay from that DNA at this point in time was not something that we could work on. So then we kind of moved to the next step on the component. I think that just needless to say, the value of cooperation and multidisciplinary work has just been tremendous. Finally, I would like to acknowledge both the Arkansas Department of Health and Arkansas Children's Hospital CF Center for their commitment to improve the newborn screening for CF. I think that the participation in the QI work has strengthened the relationship between the Department of Health and the CF Center. Now when we call, we have a face to the name, and I think that that creates, in a way, some probably more accountability in the sense saying, yes, I need to answer right away. Finally, I will remiss not to mention sort of the benefits of our participation in the CFF Newborn Screening Collaboratory. And I did not disclose, but Marcy is not paying me anything for that yet. So we'll have to negotiate that. But I think that it's really important to say that the collaborative have supported different states in our QI journey. It has provided a learning environment, and I think that you have to be humble to see that you can learn from others, and I think that that is important. And it was really a good venue to exchange resources, and as I mentioned earlier, we changed some of our practices based on what we heard from others, and I think that this is really very valuable. And I think that with 20 seconds left, I'm done.
Thank you so much, Ariel. We'll take questions. Dr. McCauley?
Hi, is this on? Oh, yeah, it's very on. You were very on, Dr. Belinsky. Congratulations. Great work. I had one question for you regarding interactions with primary care providers, and particularly if you provided talking points or other targeted education so that they both improved their referral rates but also had good, accurate communications to families.
Perfect. That's a great question. I'm always worried when Dr. McCauley comes to the microphone and you are speaking, but I think I can answer that with accuracy. I think there are two things. We recently, I think that was 2 or 3 weeks ago, we did grand rounds at our institution to discuss newborn screening for CF. We went through every single one of the reports that they can receive from the Department of Health, and we show them what they meant and what they did, what they needed to do. Secondly, we continue our participation in the newborn screening collaboratively, but this time we are focusing in the communication with the primary care physicians. So we are in the midst of reviewing some of the good work that has been done already and see how we can adapt that. And we are just planning on inviting at least a representative from pediatric group and family practice group, because I think we don't have to forget that it's not only the pediatricians who are taking care of this, but it's also the family practice dogs. So we're planning to just get their thoughts on what they understand when they get this notification, and then make modifications accordingly.
That's wonderful. Thank you. Congratulations. And I'm going to beat Marcy to this. Publish your work. Thank you.
Thank you.
Hello, I'm Joe Walter from Tulsa, Oklahoma. So I have a question just to clarify your state's algorithm for testing. So it looked to me like essentially the state health department often ends with an inconclusive state test and then relies on essentially the primary care provider to order the sweat test to get to a definitive test result. Is that accurate?
No, so the way it works is it's a problem. So we sort of learn in this process the following. So the first IRT, if it is either elevated, and we have a kind of a weird or a different situation because we have a 98 floating, but also we have an absolute 100. So we use those two. So when they ask me, do you have a very high IRT? Well, if you, I listened yesterday to somebody from Colorado, and now 100 is going to be there very high. So I guess that we're doing very high. We've been doing that for a while. But those two get notified to the birthing center. They don't go to the pediatrician. And that's what happens is that if they are efficient, they will upload that into their electronic medical record, and the family will learn first than the pediatrician. So that's one thing. The second thing is that it has a two-tier. So we do IRT, those who are in those two categories go through DNA analysis, and those who have no mutations then send a letter saying, you have no mutations, you don't have to worry about it. But that goes to the birthing center, doesn't go to the pediatrician. So that creates some problem there. If you have at least one mutation, yes, the pediatrician, they verify that the pediatrician is actually the doctor of that infant, so they can send them the information, and then they ask them about the referral. And if we don't hear from the referral within 48 hours of that happening, we sort of initiate also the contact. We are contacting them also from Children's to the PCP to make sure that they send us the referral.
So, yeah, but so from a state perspective, though, they're essentially punting that work elsewhere, right? They're getting to the point of single mutation, elevated IRT, inconclusive final result, needing a sweat test to clarify diagnostic certainty. And the state of Arkansas is considering that adequate as a state screen and then punting that work to you guys and the PCPs to sort out the definitive result. Is that accurate?
So I'll tell you that so we have a single center. Every single one of these patients either have a sweat test or are seen by the pulmonologist. So it's up to us actually to define, and we have a genetic counselor that works with us. So every single of these patients that end up being either carriers, have CRMS or have CF, receive both counseling and evaluation. Actually, we do not see the patients with that are carriers, but the other two are seen by one of two pulmonologists that are focusing their work there. So that then communicates, and we coordinate both the sweat test timing with also making sure that we can provide the consultation for those patients as well.
I have a question for you. Or actually, first, I just want to say congratulations on this work. And you really demonstrated the importance of building those collaborations with your newborn screening program, going to visit the lab. and also seeing what the sphere of influence of your combined team could do, that you couldn't change when IRTs happened or the DNA, so what could you change? And you've made a great improvement there. So that's, congratulations. Well, then my question builds a little bit on Susanna's from earlier. When you said that if you don't, you have that urgent callback now for a sweat test. If it doesn't happen within 2 days, you call the families. Have you had any pushback from pediatricians? Have you had to use that?
So as I said, initially we used it about 60%, and then that reduced to, I think, 20%. We have not had complaints of pediatricians saying you called, and I think that they are probably, in a way, thankful that we have handled that for them, and we have provided the explanation of, you have a positive newborn screening for CF, this is what it means, and now you need to come and have a sweat test. So, but we are always open to hear complaints. This will be the first time.
Can I ask a quick follow-up question to that? How have the parents responded to receiving the information from a provider that they don't know as opposed to their pediatrician?
So I cannot answer that because we sort of have not explored that. I can tell you that the patients that I've seen, and I probably see half of them with one of my colleagues, nobody was complaining that somebody else called them. They actually were relieved that somebody was helping them with the diagnosis. I think that maybe at the beginning you might say, oh, somebody else is calling me that doesn't know me. But the reality is that if it's your first child and your child we are sort of a heavily Medicaid state, you probably don't have a PCP sign yet, and that's also a problem. And that's where we sort of still are able to get them in soon enough to lower this age at first event.
Excellent. Thank you again. This was a great presentation. And next, I'm very pleased to introduce Dr. Clement Wren, who is a pediatric pulmonologist at the Children's Hospital of Philadelphia and a professor of pediatrics at the University of Pennsylvania. Dr. Wren.
Thank you. Thank you. Before I start, I just want to say, I think that I'm also really impressed, Dr. Berlinski, that you actually went to visit the NBS lab. I think that's a fantastic example that we should all consider. So I want to thank Dr. Lindemann and Dr. Sontag for inviting me to speak, and all of you for attending. So today I'm going to talk about CF newborn screening notification practices and time to evaluation. These are my disclosures. I got to stand I can't stand super close to the mic, otherwise I'm too close to the screen, so hopefully you can hear me. So the benefits of CF newborn screening require prompt evaluation and treatment of infants with an out-of-range NBS result. And the thing is that we know that both NBS algorithms and notification practices vary across the country. But little is known about the relationship between state notification practices for an out-of-range result and time to evaluation or treatment. So with that background in mind, our objective was to use data from the CFF Patient Registry, the Center for Public Health Innovation, CF-NBS Collaboratives, and the CF-NBS QI Consortium to study the relationship between state notification practices and CF Center involvement in infants with an out-of-range CF-NBS result. So it's very interesting that it's actually very hard to actually get this information on notification practices. If you go to state NBS websites, they just tell you, yes, we do newborn screening. And so we really actually had to dig to get this information, primarily through two sources. The first was the CPHI NBS Collaboratives, which you've heard about, and we've surveyed 51 NBS programs because we have 50 states and the District of Columbia, and we got responses from 44 states. Similarly, we have the CF-NBS Quality Improvement Consortium supported by the CFF, and this is a consortium that's been around actually for almost 20 years now. It was initially started to created to help implement CF newborn screening to evolve towards quality improvement. And once again, we have somebody from each state plus DC as a representative, and we got responses from them as well. So between these two data sources, all 51 state plus DC programs were represented. And turns out that there were sometimes some discrepancies, perhaps because we didn't word the questions exactly the same way or as clearly. So we did have to do some individual outreach to clarify some of the discrepancies. So that's where we got our data, and we used the same age at first event definition that Dr. Berlinski used and many others. We, first of all, to derive the AFE, we used data from 21 to 2023 from the registry, and the definition, which is from the paper that Dr. McCauley's lead author on from JCF 2022, was the earliest of the one of following events: sweat test, clinic visit, or hospitalization, which can also unfortunately happen to some babies with CF. So just kind of looking overall, this shows the AFE by state, again, during those years that we looked at. This green line represents an AFE of 30 days, which is sort of your target. And so as you can see, overall, actually, if just as just a kind of a side observation, you know, the vast majority of states, 82% of them, have an AFE under that time period, although some of them are kind of like right at the edge. I think most people are aware that there's different ways of doing newborn screening, and we have 1 screen states and 2 screen states, and we took a look at that as well, and that's divided here. The 1 screen states are shown in blue, whereas the 2 screen states are in gold. And you can see actually the median time in a 1 screen state is lower. It's 18 days compared to 24 days. But again, if you kind of look at each state, and again our kind of goal of 30 days, you can see that there are 2 screen states that easily meet that goal. So although it's true that in general it may take longer, it just shows that there's many other factors that contribute to AFE. Another thing that is clearly affects that or is related is the number of variants detected. So we kind of derived this by, again, trying to look back at the variant panels from each state during these years of the registry that we looked at. And then, of course, we had the genotype in the registry. So this figure shows the AFE by the number of variants detected. Density is basically the way the output comes out. It's basically the frequency, but kind of normalized for the total number, because of course we have way more 1 variant positives than, well, actually 2 that have CF than 1 variants. So as you can see, as with the green peak, that not surprisingly, infants with 2 variants detected had by the shortest AFE, whereas those 0 variants, which would be those babies with very high IRT, had a much longer AFE. And importantly, not only can you see the difference in median, but I think when you look kind of at these outliers beyond 50 days or 100 days, you can see that especially the 0 variant babies tend to be much more prevalent in that group. So this table summarizes some of the key differences in notification practices. And I have to say that this table actually belies the complexity, because even within these things, like when we say like the CF center being notified, it turns out it would depend. Like there's some states where they only notify centers of 2 variant positives, and So it's even this kind of simplifies it, but just sort of from this somewhat higher level, you can see that the majority of states are notified, but there's about 24% of states where really the CF Center actually has no idea what about a positive newborn screen. And again, it can vary whether or not the center is notified. There are 2 states where, and again, I'm using state, even though I know DC is not a state. Apologize to anyone from DC, but just for simplicity's sake, there are two states where really only the PCPs are notified, regardless of the number of variants. So it's really it falls on the PCP to initiate care. There's variation by region, although again we have 16 states where there's only one CF center in that state. There's variation in terms of like who orders the sweat test and who schedules it. And finally, some states provide funding to CF centers, either through a block grant or a capitated rate to close out out-of-range results. But that's actually the minority. That's about 29%. In the majority of states, CF centers just do this because as an unfunded mandate. So we did try to look at the relationship between some of these notification practices and AFE, and I do have to say I think this is still a preliminary analysis, and we may actually have to look by center versus state. But this slide summarizes some of the kind of these preliminary findings. When we look at who was notified, you can see that the median AFE for those, again, it's only 2 states, so got to be a little careful about how we interpret this, but you can see that AFE is like 35 days versus in the 20s for the states where CF centers are notified for at least 2 variant positives. I don't know whether we could see a lot of difference by CF center referral, although again, but typically if one is like named, it seems to be a little bit lower. And again, it seems like it's good to either have somebody responsible for the sweat test versus no one, because probably when it's no one, each person assumes the other person's going to do it. And at least right now, again, we didn't really see a difference between CF center funding, but again, there's a lot of complexities behind that, because we also have to see whether or not there's a tracking team in the Department of Health and things. So we're going to try to investigate that a bit further. So in conclusion, just in general, we can see that AFE varies widely across the United States, although most states have an AFE less than 30 days. The median AFE in 1 screen states is shorter than that of 2 screen states, but there are 2 screen states that can get down to an AFE less than 30 days, suggesting again that you can develop systems in 2 screen states that result in prompt evaluation of NBS positive infants. Notification practices for a positive CF NBS vary widely across the country, and our initial analysis has identified potential notification practices associated with longer AFE, and we have numerous of additional steps that we're planning to do, looking at variant number and notification practices, looking out at sort of prolonged AFE versus just median, because in a way that's really the more important thing is babies who have markedly delayed diagnosis, and maybe doing some multivariable modeling so that we can kind of account for confounders. Overall, I think that our analysis has just shown that this is another potential area that can contribute to disparities in timeliness, and we should just we include this as another factor that we analyze. So I just want to acknowledge a few people at the CF Foundation staff. Judy Zippa and Stephanie McCabe really helped with getting these surveys out. All the members of this CF NBS QIC and the collaborative who responded both to our surveys and follow-up emails. All the individuals who contribute to CFFPR data, and then our funding from the CF Foundation, both Dr. Sontag and myself. Thank you guys again for attending, and I'm happy to take questions.
Thank you, Dr. O. There's a number of questions. Deanna?
You want to go first?
I'm going to go with Dr. Smiley.
Hey, Clement. Mike Smiley from St. Louis University.
Hi, Mike.
How are you? Excellent talk. I'm bringing this up. So I'm in Missouri, and we have 9 states that surround us. And Marcy and I, on part of the collaborative, we tried to do a border state initiative because one issue we run into is in St. Louis. We're close to Illinois. And Illinois has Chicago and the rest of Illinois. So we, Southern Illinois, you remember from your time in Indiana, takes care of like Southeastern Illinois. St. Louis takes care of Southwestern Illinois. And then Tennessee does like Southern Illinois. We found a lot of hurdles with interstate collaboration because of various regulations about sharing data and stuff. I want to see if you have any suggestions about that, because state to state data is great, but at the patient levels, our patients aren't confined to states.
Yeah, Mike, that's an excellent point. I think that happens at a lot of, we in Philadelphia, we get New Jersey referrals as well as PA. So I don't know if I have specific things. I mean, I can tell you that I attend both the New Jersey and the Pennsylvania newborn screening meetings that we have kind of either every month or quarterly. And so I think that is, one thing, and just trying to, I think in general, it's just, it's kind of a theme I hope, and I think we'll see throughout today is, that's why it's so valuable and important for us to partner with the newborn screening programs, the state newborn screening programs at each of the states that may refer infants to us.
It's challenging.
Yes,
Thank you.
I do relate. Thank you.
So Deanna Green, Johns Hopkins, All Children's Hospital, St. Petersburg, Florida. Dr. Wren, I hate to give you more work, but I believe you're going to see an inflection point in 2025 after our new guidelines came out. I think many states are changing between reporting 2 variants and 1 variant only to the CF centers, including my state of Florida. And so I'm wondering if you're going to plan on analyzing all of the data pre-2025 and then with all of those changes.
Yeah, it's a great point. I think, newborn screening, any of these analyses, it's kind of like a moving target because everybody's algorithm is constantly changing, and even, notification practices may change. So I think so one of the things, as part of the QIC that we want to do is really try to create more of a living or real-time document or database of these things so that we can update it regularly and then be able to cross-reference it with the registry.
Great talk. Chris Syracuse of Cincinnati Children's. Wondering in your analysis if you pulled data on racial and ethnic backgrounds as part of this, and if there was any discrepancy between AFE and different racial and ethnic groups as has been described in the past.
Yeah, no, great question. And the short answer is no. And that's why I'm definitely, but that would be something that we could do in future modeling, or also in some of these multivariable models is include some of these demographics.
Phil Farrell from Wisconsin. Thank you very much, Clement. That was quite interesting. Like all variations in CF newborn screening, this is really challenging. So I have a question for you and perhaps for Marcy. We know from various surveys that up to 1/3, or even in some states half, the PCPs are unknown at the time the dried blood spot specimen is obtained. In other words, doctor's name on the Guthrie card is uncertain, and sometimes it's fabricated by the person who obtains the blood. So how do you factor that into this project and future studies? And also, I just wanted to point out that's one of the strongest arguments for concurrent notification of the CF Center.
Yeah, Phil, thank you for. That's why I said that even our a simple question like who is notified, right? There's a lot of granularity behind that. We discovered some of that, and I think that again that's something we can. I think it's going to be too hard to look at a state level just because then you get so much variation for a relatively small number. But we might try to do that at a center level and try to understand better which at each center really how reliable is the PCP name listed on the dried blood spot card.
I would just add to that I think those numbers I'm hoping are out of date now, the 1/3 or 1/2, and newborn screening programs are working very hard to find solutions to that through interoperable methods and other ways to get those data so they have that PCP and are able to act on it quickly. So that's also a quality improvement activity that's happening at the newborn screening program level.
Great.
All right, are there any other questions for Dr. Wren? Thank you so much, Clement. That was great. And now I'm pleased to introduce our next speaker, Dr. Caitlin Krivchenya. She is a pediatric pulmonologist at Nationwide Children's Hospital, an associate professor of pediatrics, and the Ohio State University College of Medicine. Caitlin.
Thank you. Thank you. And thanks for letting me come here today and really share our work on behalf of our Ohio team. So my name is here, I'm speaking, but it really is the work that we've done in Ohio that was supported by a SIP grant. So I want to share with you today work that we've done to try to move Ohio forward. But first, a little bit about Ohio. We have a pretty varied geographic as well as kind of cultural background in this state. We have flat plains where they're, well, not really plains, flat farmland, I'll say. We have rolling hills of Appalachia. We have places we can hike and camp, but then also some pretty thriving urban centers, often on a beautiful river or a great lake. We're the 7th highest population of all states. And with that comes about 128,000 live births annually. And we are blessed to have 7 different newborn screening centers, 7 different children's hospitals that work together to try to make sure that all our infants with abnormal newborn screens get the care they need. We work closely with the Ohio Department of Health. There are 2 staff members that manage all newborn screens for these 128,000 live births each year, not just the CF-related screens, any abnormal newborn screens. As many public health departments across the country, we need more staff and more funding to try to help this burden. Our state lab can't do things like data pools for organizations that are trying to help make things better because of the staffing. So as a group, when we looked at the status in Ohio, there were some problems we needed to address. As of spring of 2024, there were 445 unclosed abnormal CF newborn screen cases in Ohio. Now, this doesn't mean that those babies weren't getting care. It just means that the ODH, the Ohio Department of Health, didn't know about it. So we had 445 open cases. And this really impacted our ability to track the performance of the newborn screen in our state, and then also to get accurate representations of the state of CF in Ohio. We have, for various reasons, over time, there has been inconsistent communication between centers themselves, but then also between centers and the ODH. We have very different ways of notifying families, which is why that state-based approach can be really challenging when we're trying to collate all this information. We have it 7 different ways. And then we have worked for a long time with a limited genetic panel. So we're an IRT DNA state. We have a floating cutoff at 96th percentile, and then a limited genetic panel. So our process map would look something like this, where the ODH processes the blood card. We run the IRT and then run CFTR analysis about 3 times per week. And then if 1 or 2 mutations are identified or variants are identified, the ODH staff actually picks up the phone and calls the PCP and then faxes the abnormal report to one of the 7 children's hospitals based on the region of the state. And then every individual hospital has their own center-specific ways to notify family, arrange sweat chloride testing, sequencing if needed, and genetic counseling. And then prior to this project, really very separate ways of letting the ODH know so that the case could be closed. So with the help of SIP grant funding, we put together our team. These are only the people that consented to their pictures being on for everybody to see. So we have about 25 members total that will end up coming to our regular calls, including dedicated people from the ODH. And then we have physicians, nurse practitioners, nurse clinicians, and genetic counselors from across the state. We also have 2 parent representatives that have been really helpful as we try to work through some of these things. So I'm going to just show you some of the interventions that we've done that have been helpful. Really, it's mostly just setting up the space to communicate regularly with one another and get to know each other as people. And we've done that with regular virtual meetings about monthly right now. And then we also had an in-person conference in February in Columbus, which is where our lab is located. And Marcy was actually able to join us along with Dr. May Baker from the Wisconsin lab. One of the things that was helpful is actually to set up a shared Teams page for all of our different centers to use around newborn screening. This allowed us to really share the documents we were creating, to have a living space where we could make updates that were dispersed across the state. We updated contact info, which is like super low-hanging fruit, but the ODH can't give us information that's important if they don't know who they're contacting at each center. And that's now a living document that changes as jobs change as well. And then the ODH now sends us a center-specific quarterly report with all the open cases that they have in their database. And so now we can get feedback directly about our specific center to see how we're performing. One of my favorite things we've done is creating this standardized reporting form, so a fillable PDF form that each center uses to close the case and send it back to the ODH. And what we've done is not just, this is the diagnosis, these were the sweats, but also why couldn't we maybe close that diagnosis? Was our family refusal? Were there issues with financial, transportation barriers? We couldn't get a hold of the family, and we left some wiggle room in for if there's interesting cases that had a barrier that we didn't foresee. And then also trying to help the ODH out with, is the PCP correct on the newborn screen? Because often we know that before they do. And over time, we really have seen some good improvement. So we've reduced our open cases over time by 58%. We'll never be 0 because babies are still being born and creating new open cases. But we want to see that number continue to get lower and lower. There is the other reason this won't be perfect is because we have the state divided into 6 different regions. There are areas, just like you have border state issues, there's border county issues where a kid may be on one person's case as opened and then another person's region as closed. And so there's some data issues, which because of staffing at the ODH, we're not gonna have a perfect system. But we really like this trend. We've also done some education interventions, mostly working with the Ohio American Academy of Pediatrics. We had several members work on a statewide webinar on general updates about CF and prognosis of CF in this new phase of care, as well as newborn screening, and then highlighting some changes coming to Ohio's newborn screen. We did a focus group with Ohio pediatricians to really ask that question of, do you feel like you need to be the ones being notifying families, or is it okay if the CF Center does? We had parents weigh in on that as well. Publications in a quarterly Ohio AAP newsletter, and then also a newsletter that will go out through the ODH to all the primary care providers, updating them on changes to the newborn screen. and most importantly, where the newborn screen will fail us, even though it's getting better. So let's talk a little bit about that. So we were informed in the summer of 2024 that there was going to be a transition to the IRT DNA sequencing algorithm, and we're happy about that. This is certainly one of the things as a group that we would have advocated for, but this was very top-down decision. The governor had read some lay publication about Trikafta and CF and how great it was, and that there were inequities in the newborn screen, and said, hey, this isn't okay. We need in Ohio for every baby to have the same access to diagnosis of CF regardless of their ethnicity. So that was really great. Top-down decision, this is going to happen. That was summer of 2024. It is now, we are still waiting, but we think it'll happen in November now. So working closely with the University of Wisconsin lab, so Dr. May Baker, the ODH is working with them to contract our sequencing testing. And then, because of the timing of all of this creation of the Ohio Newborn Screen Collaborative, we were really able to work hand in hand with the ODH to try to help guide the process to make sure that we were all informed and adapted these changes appropriately. To do this too, also wondering about our IRT cutoff, how well is it performing? Well, finally, we had a group of people together that could share de-identified data to try to see how well that IRT was performing. So we gathered data from all false negative CF newborn screens from the prior 15 years. These are often things the ODH wouldn't know about because maybe it's the kid who's 12 and gets diagnosed, but their newborn screen was normal. That doesn't necessarily go back to the ODH. So at each of our specific centers, we used our CF Smart reports, but then also for kids that weren't in the registry to make sure we were capturing everyone. And really trying to balance this like number of infants that we would have flagged if we had like a lower static IRT cutoff with the cost to the state, now that we know we're doing this CFTR analysis. And we ended up adding a static threshold of 65. So we're still using our floating threshold, but 65 is going to be our lower static. This all makes us feel a little bit better, but in truth, when we looked at our false negative cases, most of the false negatives had IRTs in the 50s for our state. And so to really make that lower limit of 50, we were talking hundreds and hundreds, if not 1,000 babies each year now needing extra CFTR analysis. So it was a little bit of a cost evaluation. We could have made the recommendation and the ODH could have said no, but we ended up going ahead and settling here. Now, this collaborative input has been it's been a fascinating process. We know the ODH people, we interact regularly. We have very compassionate, well-meaning people in this collaborative that all want to do the right thing. And we can give our recommendations, but in the end, the state lab is the one that's contracting on this CFTR analysis, is making the decisions about can we pay for this. And so our group has been trying to just make sure we really understand the data we're going to be getting, and then how are we going to respond? So one of the questions that programs ask as this is happening is what variants are reported. And what was decided for us was that we aren't doing any variants of uncertain significance, and most of the VVCCs will not be reported, with the exception of the R117H with poly-TG and T tracks, poly-T tracks. And this is consistent with what University of Wisconsin lab does with their CF center, and so we're starting there. All disease-causing variants will be reported. We were able to change the language for each of these results and work with the comms team at the Ohio Department of Health to make sure it's all in line. And then the discussion of really do we adapt the recommendations from the guidelines that we only call out the 2 variant kids and only sweat the 2 variant kids, or are we going to continue sweating the 1 variant children? This was a robust discussion, and actually during our in-person conference, we had a whole afternoon set aside for like process mapping and like really good QI stuff, and we just really talked for 2 hours about what do we do about this, like what are we comfortable with? And we've got a lot of cooks in the kitchen, right, which is good because, again, all these people care, but then also trying to come to consensus about something like this is really, really hard, and there's big feelings. So I was going to share some of those with you. So for some of our members, not reporting those VVCCs makes it harder to let go of sweating those 1 variant kids, this idea that we could be missing something, this information is there and we just don't know about it. Shouldn't we know so counseling can be done? This is often where we end up with our CRMS kids. Do we lean into more of those diagnoses just because of the potential risk, or do we say that it's okay not to know? Ethically, what is our obligation as a genetic counselor to inform parents of that potential risk? It feels distressing, really coming to the consent, it's like to understanding that nothing's ever going to be 100%, particularly when we think about all the kids we missed with our IRT cutoff. That's not going to be 100% either. So how and what percent are we going to accept as feeling comfortable enough, right? And so these are all just, there's nothing scientific about what I'm sharing with you right now, but I just wanted to share like the distress, the emotional distress that this decision actually brought out. And then just the actual, what is it going to do statewide and center specifically to our sweat testing resources? We expect there to be more children with one mutation recognized when we move to sequencing. What about our QNS rates? Some of our centers have a harder time than others. Are we going to have an impact there? What are we going to do with our CRMS cases? What do we do with our genetic counselors? We have robust genetic counseling in Ohio in general. If we only sweat the two variant children, what about all that genetic counseling for the one variant children? Like that's a great proportion of like part of their jobs. On the flip side, if we go ahead and sweat all the one variant children, then do we have the bandwidth? And some of our centers, their physician sees every single one variant baby. So do we have that bandwidth? And again, remembering, it still relies on the IRT. We're still going to miss kids. So that message of CF newborn screening is just a screening test. And when we take a step back and we say it's just a screening test, it's not a diagnostic test, then it maybe gets a little bit more comfortable letting go of that sweat. But all that being said, for better or worse, here's where we've ended up. Blood's going to go to the ODH. Then if the IRT is elevated, there's going to be an extended panel testing. If there's zero variants, we no longer are going to have a high IRT zero variant call out. This is called out as low risk because we are really confident in the lab's ability to test for coming up on all disease-causing variants. If there's two variants, then CF care will begin. We will sweat test at that point. For now, if there's one variant testing, then the UW lab will go ahead and reveal the sequencing information. If we find another variant, that again goes into our care. And for now, as if there's still one variant, our hospitals are taking ownership of saying, we still want to sweat these children. We think we have enough resources in the state to do this. This is a trust but verify situation where we trust these humans that have made these guidelines, but we feel like we need to do some verification before everybody in the group's going to feel comfortable letting go. If the sweat is normal, we're done. But what if, and this is the doomsday scenario, we have one variant, we have sweat testing that is intermediate or abnormal, and they've already been sequenced. What do we do? That's when we would reach back out to UW, see if there's any VVCCs out there that we should be aware of for this child. And we're going to see how it goes, and we're going to reassess in 6 to 9 months to a year and figure out what we still want to do. So our ongoing plans, again, this has been in the works for a really long time. It's been 5 or 6 weeks away for several months, but we think November 5th. So we're excited about that. And we have now prospective plans to monitor time to family notification, time to sweat testing. What does this do to our genetic counseling capacity? This also buys us time to figure out how we are going to adjust as a state to just sweating two variant kids. How do our genetic counselors' time need to be shifted? And then ongoing education of primary care sites, understanding this is just a screening test. So with that, I have a QR code, and then there's a handout, I think, associated with this. If you want to take a look at our newborn screening report form or our KDD, you're welcome to please join, or we're at poster 413 to talk more. That went a little over, sorry. Yeah, thank you.
Any questions for Caitlin?
Caitlin, this is Nate Kranack. I'm from Cleveland Clinic Children's. First of all, I had the opportunity to sit on the Newborn Screening Advisory Council way back in 2028, or sorry, 28, back, when I thought I was a lot younger. And, you bring up a lot of issues that we really struggled with way back when, and I sat on the Newborn Screening Advisory Council for about 5 years. And, we had a lot of things that we were concerned about, including these kids that we were missing. Are we doing the right thing? Are we sweating the right kids? How many mutations should we have? And the one problem back then is that it was me. And you've awakened a lot of anxieties that I had and that I had suppressed for the last, many years. But what a great job of bringing all of these centers together and, seeing what we can do when we all work together. And I want to thank you for that. Great work.
Thank you. Thank you.
Good job, Caitlin. Caitlin was my old co-fellow many years ago. So question for you. So if the goal of newborn screening is to not miss any cases, I don't understand the rationale about not reporting VVCCs, especially in the context of the new CRMS guidelines, right? It's not the Wild West anymore. We have guidelines. Sweat them once a year, follow them clinically, right? So I think in the past, there was more harm being done to those CRMS children with annual labs and all this other nonsense, right? It's about the sweat. And some of those VVCCs may be reclassified in the future, right? And some of them are higher risk than others. So I guess my question is, why did you guys decide that?
Yes, and I hope I do some people proud here, trying to give the counter argument is that the point of CF screening is to catch cases of CF. And yes, we don't want to miss them, but we know we will regardless because our test is not perfect. The point of the newborn screen is not to diagnose CRMS, right? That's a byproduct. So what it does highlight though, Mike, is that we need to make sure that in our counseling of these families with the one variants that we are including education about, again, always looking for the CF. And it really is, you double down on the education of the primary care providers and the team in general, that if you looks like CF, we get the sweat test. The VVCC decision was one of those that it was the top decision. It was made between the labs. And so it's what we're working with. I think it does make it harder for us to stop sweating the one variant kids, right? I think had the VVCCs is going to be reported, I think we would already be at, let's just sweat the two variant kids. So good point. No good answer.
This is Megan McGarry from Seattle Children's. First of all, excellent presentation and excellent work. So my question to you is, so you said you're going to be monitoring for the next 6 to 9 months to decide. So what are you monitoring? Because there's so much competing interests between costs, like the provider burden, the impact on families. So can you just explain a little bit about, have you guys decided the different things and what that process is going to look like?
Yeah, and thank you for asking that because, I think the work up until this point has very much been on, is everything ready to make this change? And what we haven't, we've got some processes in mind for how to track the logistics of it, right? And certainly if we miss a case, if this process, we end up missing a case of a child that had a VVCC that is really important, we definitely want to track that, right? Like how many of those VVCCs, but then the argument could be 6 to 9 months is not enough. That's like over years, we're going to see those cases. So the question at my group as a whole is how much info do we need to be comfortable with moving it along? And my gut, speaking for the various centers at my state, is that we will get there pretty quick, especially when we see what this does to our resources. We almost need just time to figure out how we're going to adapt our education, our genetic counseling, how are we going to set this up so we can do more of that education about this possibility in the future, that there's still more out there. I don't know that I really answered your questions. We got a little bit more work to do on what exactly we're measuring.
Hi, this is Silvia Delgado. I'm in Florida, which I guess for those who don't know, like we got the next gen, which has been like an adventure in general because we get to report everything. So great presentation. Thank you for sharing too. But I just want to go back to like the variants of unknown significance. I think, if you do the sweat test, it's a good thing because if you have a borderline, that you may repeat it again. But I will say, like, would you include then like the ones that are in CFTR2 that says that this disease sometimes can cause disease, sometimes cannot? lately have been encountered that very, very frequently. So it's like explaining that to families, especially with the borderline sweat test, and then they go automatically CRMS. But some of these patients now, like, they're growing pseudomonas. Now they have so it's like a spectrum, and I understand we don't want to tell someone that they don't have CF, that they have CF, and how to tell them we still need to look at you just in case something happened. But I would just say, like, would you include these ones that are like described, like some people in the registry have CF with this mutation and sometimes you don't? Would you call it pathogenic? Because I don't know, I guess those you probably should include, although they're still called a VUS. I don't know, just a suggestion.
No, it's really hard. And I think one of the things that had come up at our QIC meeting yesterday was like, is there work to be done to help us figure out which VVCCs or VUSs really, if you, as a state, if we wanted to add some, which one would we choose to add? And I think the lab will work with us. But at this point, as a state, we don't really have that guidance, right? So, great question.
We have time for one more question.
Hi, really great talk. I think it's a really relevant topic in light of so many, like, sequencing now that it's become so prevalent. I'm Jackie from Oregon Health and Science University, Dornbecker Children's. It's also really good to see that Ohio has so many children's hospitals. But speaking more from the theoretical side, so when you genotype someone, it's not all the genes are expressed, so it's all like the phenotypes are what's being expressed. So sweat chloride, I would argue for sweat chloride testing because we can better characterize the variants, all variants, and there's so many intermediate sweat chloride tests that maybe even the ranges could be changed to be more accurate.
Yeah, well, and the counterpoint to that would be is some of these the VVCCs, they don't have an abnormal sweat, right? And so just like our pancreatic sufficient children are less likely to be caught by the IRT, some of these rare variants aren't going to elevate your sweat. And so it's also letting go of those kids. Even if we do sweat everybody, we're still going to miss people. So I do think especially like the messaging of, hey, our newborn screen is getting stronger is it worries me a little bit, right? Because we still need to think of it as just a screen, no matter how strong we make it. And so that's just what we've struggled with in our state of like trying to make this decision.
Like, we don't know too much about all the variants, so getting more information would be helpful for everyone.
Yeah, but then we have to balance that with the family distress, right? Like we've like labeled them with the CRMS, and like, what does that really mean? And what are they going to follow? Their kid might be 60 by the time they have symptoms, so it's tough.
Great.
Thank you so much. I think we're going to have to stop there. I do want to mention that the Florida experience was recently published in IJNS, so that's a good article to read to learn about their experience expanding to reporting all variants via next-gen sequencing and continuing to have sweat testing. And our next speaker is Dr. Melanie Collins. She's a pediatric pulmonologist at Connecticut Children's and associate professor of pediatrics at the University of Connecticut School of Medicine. Thank you. Whoops. I'm old. I need my papers. I'd like to thank Marcy and Rachel for asking me to present on our newborn screening program, which is a combined program between UConn Health and Connecticut Children's Medical Center, the Central Connecticut CF Center. Here's my disclosures. I have no disclosures related to this presentation, but I do have a bias that genetic counseling for CF newborn screening and CF should be performed by a CF-trained genetic counselor. I would also like to note that this work is a collaborative effort with the UConn Newborn Screening Lab, Drs. Hopfer Lasala, Marta Urban, and Mukhtar Suleiman, and the University of Florida Hayward Telegenetics Center with Heather Stalker and Amy Jonasson. My objectives today are to discuss the challenges of creating a high-functioning newborn screening program for CF,
to describe the integration of next-gen sequencing and telegenetic counseling, to summarize evidence supporting the use of telegenetic counseling, discuss strategies to optimize communication, disclosure, and follow-up for infants with CFTR variant findings in the newborn screening process, and lastly, to review our funding structure, if you could call it that, for CF newborn screening. To help set the stage, I'd like to present a case that is near and dear to my heart, and perhaps to get everybody in the audience fired up a little bit this morning. Parents are confused as their infant with echogenic bowel was diagnosed as a delta F508 homozygote via amniocentesis. As their first child was healthy, there was no maternal prenatal testing. The parents and the older sibling were identified as delta F508 wild type, and the older sibling, who had been born in a state that was not Connecticut, had been identified on newborn screening, and this had not been disclosed to the family. Now, this infant with CF becomes a child with CF and an adolescent with CF, with multiple comorbidities, surgeries, and hospital stays that were so interesting, he was actually presented here as an infant with cystic fibrosis when I was a fellow. So his mom leaves her career as an ICU nurse to care for this fabulous child, but the family struggles financially, adding to the social emotional burden of CF. And I ask you, was it right to not disclose the single CF variant result? Now, one of the topics I was asked to cover today was our challenges and our successes. The key to our success started at UConn Health in 1975 with Dr. Sid Hopfer. Incidentally, this is also the year of my birth. CF newborns, which I used to think I was young, but now I realize I'm old. CF newborn screening began in the 1980s with Michelle Cloutier, who introduced IRT. And in 1993, the year I graduated from high school, thanks to the collaboration between Dr. Hopfer and Dr. Cloutier, CF newborn screening officially began at the UConn Health with an IRT Delta F508 homebrew, as Sid calls it. As the program prepared for my arrival in the 2000s, we gradually expanded our mutation panel from 27 to 43, and in 2004, learned a very valuable lesson when we missed our first and only baby with CF, who was a sibling of a child with CF, but the IRT was low, and thus the child's mutation panel was not analyzed. We have promptly added a family history checkbox to our screening cards, which results in reflex mutation analysis. In 2008, when I joined the CF Center, Dr. Lappin gave me the newborn screening program because it would be an easy job for me to do. And in 2008, Dr. Hopfer and I published our first paper together on the benefits of newborn screening in nutritional and pulmonary outcomes. We have continued to advocate in our role, and in 2009, despite being one of the very first states that implemented newborn screening, we were the second last state to develop an unfunded mandate for newborn screening. We joined the QIC in 2011, thanks to the graciousness of Dr. Marie Egan, who nominated us for participation. And in 2013, we radically changed our program when we incorporated one of the SIP grants and started telehealth at the time of sweat testing. We did multiple posters that we presented to NACFC, gradually moving to a 60 mutation Luminex panel. And in 2022, again, inspired by QIC collaboration and relationships, we started next-gen sequencing. Our goal had been to implement next-gen sequencing at UConn Health, but as it was not financially feasible, the good folks at Wisconsin were gracious enough to collaborate with our program, and I cannot tell you how happy we have been with that collaboration. In 2023, we published our paper on telegenetics, which I'll talk a little bit more about in the next slides. And in 2024, after a lot of heel dragging by Sid, we finally switched to a floating cutoff for IRT. If you're dragging your heels, please talk to Dr. Hopfer. He can tell you that he's now a believer. And in 2025, we expanded our genetic panel because of the good folks in Wisconsin to 981. one variants. And unfortunately, 2025 marks another landmark with the passing of the baton to Rocco LaSala, who is showing great promise as our data guy in the lab. Now, this is the algorithm that we follow at UConn Health. We screen approximately 2/3 of the babies in Connecticut. You enter the program with an elevated IRT or a family history of CF or clinical signs of CF, i.e. meconium-ileus, or if you have 2 parent carriers or a sibling with CF, or if you have an IRT greater than 150 nanograms per ml. These are sent to a 60 variant panel. If 2 variants are detected, we go into emergency mode and we notify the CF center. I am also notified as a double check. We follow airline safety in this program. There's always 2 checks. If there's 1 variant detected, or if it's an infant with a very high IRT or a high-risk family history, all of those are sent to the Wisconsin State Lab for next-gen sequencing. Again, if 2 variants are confirmed, we go into high-efficiency mode. We get those babies in to be seen. And if no or 1 variant are confirmed, then a letter is sent to the pediatrician who has already been confirmed by our laboratory. And then we proceed with sweat testing. As we pride ourselves on education and communication, we did communicate the addition of NGS to the program, but most pediatricians weren't really wanting to understand what NGS was or is, and most did not want additional knowledge. They said that they trusted me and the program, which I guess is one of the benefits of being old. There's increased provider confusion, though, in 2025 because we had a routine laboratory inspection that mandated new wording, and this was just listing synonym after synonym for the mutations. Providers were thinking that they had homozygotes instead of heterozygotes. Requirement of adding the Wisconsin report plus our report added to the confusion, and then we had a major health system add e-faxing, which resulted in results being lost. What's nice about this is I do have direct communication with the pediatricians, so you're able to find out this information, and we've modified our provider level letter, as many folks have mentioned here, based on our tips that we've learned from the CF Newborn Screening Collaborative. So what happens after NGS? Well, we are still doing sweat testing. Thanks to the 2014 SIP grant, we won a 2-for-1 special at UConn Health. Once we get a single variant result back on NGS, we then recommend sweat testing with concurrent genetic counseling. This photo shows our telegenetic counseling area where the sweat test is performed. And while the infants are being sweated, the parents receive telegenetic counseling simultaneously. It is peaceful and private. There are toys for siblings, and it makes the best use of fatigued parents and babies' time. Furthermore, every infant and pediatrician receives a full copy of the genetic counseling letter documenting the discussion that occurred and next steps if needed by the family. So you may ask, does this make families happy? Yes. As demonstrated in our 2023 publication in Pediatric Pulmonology, despite most families having no idea what telemedicine was back in 2015, most families were satisfied and would recommend the process to others, scoring 4.77 out of 5 on a Likert scale. Furthermore, there was no difference between the centers. This is not surprising because it was the same 2 genetic counselors who were skilled in CF genetic counseling who did the genetic counseling. But why did UConn Health get so many families, almost twice that of the next highest center? Simple. By recognizing a slow start initially, Sid and I partnered and created a letter to pediatricians to improve communication and understanding of the benefits to this free, no-cost service that happened concurrently with sweat testing and was recommended by the CF Foundation and was standard of care. And this determination paid off. We went from having about 49% of newborn screening positive infants getting a diagnostic sweat test to our new average, which is far from perfect, but is about 70 to 80% of sweat test completion per year. But it's great to make people happy, but does telegenetic counseling really work? As you can see here, We compared our telegenetic patients in the dark blue to a historical control based on a CISC knowledge inventory that was done with in-person genetic counseling, and light blue is uncounseled historical controls. As you can see, our telegenetics families performed equivalent, if not better, in all of the categories. Specifically, in 2 categories, there was a statistically significant improvement using telegenetic counseling, with 100% of our families understanding that their child was a carrier of the CF gene, and 87.5, more than 50% higher, of parents understanding that they both may be carriers for the CF gene. Sadly, in both telemedicine and in-person counseling, while almost 90% of parents understood that they carry the CF gene, only 45% understood that they were at an increased risk to have another child with CF. I think we need to reconsider the way we are presenting this information to families, as well as the need for opportunities for reinforcing these genetic counseling. Did your NGS change your reporting time? Well, despite our initial concerns that adding NGS all the way in Wisconsin might increase our time to sweat testing, it did not. Furthermore, we performed a retrospective analysis of our infants who had been diagnosed by sweat testing alone and performed our NGS panel on them. We found that we would decrease the time to diagnosis by 7 to 10 days on average, and that doesn't include the one baby that was really a far outlier that would have had their time to diagnosis decreased by 30 days. And easily all of these babies would have been diagnosed within the first 1 to 2 weeks of life. In addition, in 2022, to make sure our sweat test results were not delayed by NGS, an astute laboratory tech, who you can see here, Mukhtar, began proactively calling families to schedule the sweat testing. This decreased our time to sweat testing further after positive newborn screen. It is the partnership of the entire team working collaboratively to make things better that has resulted in the success of our program. With the addition of NGS, some programs are concerned it will increase the intermediate sweat test. And I will say every program is an individual, but for our intermediate results, as you can see in orange, babies less than 6 months of age have not had a statistically significant increase in the number of intermediate sweat tests. However, with the advent of CFTR modulator, our adult bronchiectasis center has become very committed to doing sweat tests on their patients, and we have a significant increase in the number of sweat testing and intermediate results in the adult bronchiectasis patients. So a major challenge of CF newborn screening is that it's an unfunded mandate without national procedural unification or accountability. We are not a fancy program with tons of grants or funding. And since I began in 2008, there has been no funding associated with my role. However, our determination has paid off to help us obtain funds to help our program. The telegenetics was started as part of the CFF newborn screening SIP grant. And based on the success of the program and the family satisfaction, it is now subsidized by UConn Health. With the addition of the next-gen sequencing at Wisconsin, we increased our cost of screening to birth hospitals from $16 to $20 per screen. So the negative screens do, in fact, pay for some of the additional genetic testing on the positive screen. And this was more effective cost-effective than adding next-gen sequencing at our lab. We are very proud to say that we can give each baby the very best, and that has no monetary value. Now, there is variability nationally on how programs handle single-variant results. Due to my deep personal connection with CF and our program's commitment to genetic counseling and education as part of the process, we still recommend sweat testing, which our center is collaborating with genetic counseling, so they get both. We remain committed to not missing a single diagnosis, even though we know that it will never be 100%. So here's a lovely picture of my buddy Patrick at the prom in his, what I like to think of, post-Trikafta utopia era. Patrick was diagnosed with CF by amnio after his mom Shannon, who is my best friend, asked me during my fellowship what echogenic bowel meant on ultrasound and if I knew what CF was. Her older daughter, Molly, was healthy. So Shannon wasn't offered CF testing during her pregnancy. And when she had testing during her pregnancy with Patrick, she was told it was normal by a nurse at a doctor's office. And it was normal because Shannon was a heterozygote. You read the rest of the story earlier, but somehow when you watch the challenges that CF can present to someone so close to you, it changes your perspective a bit. So on behalf of my bestie and the other families out there with CF, I ask you to please consider that when we decide not to disclose single variant mutations and provide skilled genetic counseling, we change lives. Now, I want to finish on a high note by recognizing Dr. Sydney Hopfer, who has been my partner in crime in CF newborn screening for almost 20 years and is reportedly mostly retiring this year and paid to come to this conference on his own dime. Sid, thank you for always believing in me and the program and making everything happen.
Right, what questions are there for Dr. Collins?
I think I scared everybody.
Oh, Dr. McGarry. Or they're just getting hungry, I'm not sure.
I'm pretty hungry.
So excellent work.
Thank you.
And then thank you for including like a story of a person with CF too. So with the telegenetics, what do you do when the family doesn't speak English?
Oh, we use interpretation services.
How does it, do they jump, like does the interpreter also be on the video call or is the interpreter in person in the room with them?
No. Or Sid's coming up. He might want to correct me.
Yeah, I can answer. Yeah. When we first started, we had an interpreter service at UConn Health, but the scheduling was very difficult. So recently, for the last 5 years or so, the interpretation piece comes from the University of Florida. They're much more efficient at doing that.
That was it. That was my question. Thank you.
Yep. I was just going to ask, you showed us that the intermediate sweat tests in the youngest patients stayed pretty stable, but what about your carriers, like the ones that had one variant and then had a normal sweat test? Have those increased dramatically with the sequencing?
No. And I don't know if it's because we have a more homogeneous population in Connecticut than other states. Like, I think that is something that you really have to look at in your own individual state. I don't think it's really a one-size-fits-all kind of thing, even though I definitely want some sort of national procedural guideline, but...
We'll put you in charge of it.
Excellent talk. This is Akash, a genetic counselor from Innova, and I was just curious how you guys picked the 980-something variants that you report on your NGS panel. It seems to be a little less than what's in CFTR2 for disease-causing variants. So where's the discrepancy?
So I think it would be great if I had this beautiful scientific answer for you. But I think the reality is that we partnered with Wisconsin, and I felt like anything that was good enough for Phil Farrell was certainly good enough for me. And I will say what I didn't detail on like the history timeline is that the University of Wisconsin has been consistently updating the number of mutations that they analyze on the panel, and they're not routinely doing the VVCCs save for the R117H mutation.
I'm from Wisconsin, so I'm Anna. I'm a genetic counselor from there. So just to speak to that a little bit more, we do go off of the CFTR2.org database, but as you were just saying, it's something that continuously is getting updated, and we try and stay pretty on top of that, but there might be a little bit of difference just with leg. I know May just very recently did the update to the 900 and plus. So, but that is our main source for determining which variants are included.
And I'm sure Wisconsin doesn't want like an advertisement, but it really has been an excellent partnership and collaboration. And I think being able to talk to the team in Wisconsin whenever we need to has definitely benefited us as well as the infants in our program.
Over here.
Thank you so much for this great talk and really, truly amazing work. My name is Jacqueline Davis. I am from Boston Children's. We are also working on newborn screen timeliness to first sweat test through a SIP funded project. One of our findings kind of driving late first-time sweat tests has been late referrals. And so we have been trying to think about how can we partner with primary cares. In our state, we are one of 4 CF centers. So everything goes through our state newborn screen program, but we don't hear about all of the out-of-range newborn screens because we're one of 4 programs. In some work where we've surveyed PCPs, we've learned that they're really unaware of kind of the timeliness guidelines that we're looking for the sweat test to happen within 4 weeks. We're trying to figure out how can we better convey this message to them. You alluded to at one point in your talk that you were able to reach out directly to PCPs, and I'm wondering how exactly did you do that, and kind of what partnership you have with your state's PCPs.
So we are running the screening test through the Yukon lab as well as through Yale, but we are partnering with Department of Public Health. Like my previous speaker mentioned, it's going to be any day now, starting 2 years ago. For the letter goes with the abnormal newborn screen, and I'm happy to share a copy of the letter. We've revised it several times. I embraced my Italian roots and really made it clear to the pediatrician receiving the letter that this was something that they needed to do and that the onus was on them if they did not do it in a timely fashion. And my phone number and the phone number of the lab is on the letter. So if pediatricians have a question, they can reach out to me directly. Or if they reach out to the lab, then the lab contacts me directly because we have a really close partnership. I do think in the era of email and text, we really do vastly underestimate the power of a simple phone call for clarification. But if you want to chat after, I have an idea that I think we could maybe get us to 100%. Because I see these other states at 100% and I'm jealous. So we'll get there.
And a quick last question, Dr. McCauley.
Yeah, it's just a comment for everyone who's interested in PCP communication. We created a continuing medical education and MOC Part 4 activity. We partnered with the Illinois chapter of the AAP, but it is available to everyone who has board certification or wishes to maintain that. It's on the American Board of Pediatrics portal. It's a lecture, and then you can do an office improvement for managing newborn screening tests. If anyone wants more information, this has gone out through the foundation, by the way. I'm happy to be contacted. Susanna McCauley, smccauley@lurychildrens.org. I'm easy to find. Thanks.
I would also add for those states that work with family medicine doctors, as part of the newborn screening collaborative, I was impressed that there were so many states that had family medicine doctors. So with a family medicine colleague, we wrote an article. Please don't read the article. We are very limited on word count. The article is poor, but the tables are meant to be a fast reference guide for your family medicine doctors, and it's published in American Family Physician, which is the major journal of that group. So happy to chat more.
Thank you so much. And our last speaker is Dr. Marcy Sontag, Executive Director at the Center for Public Health Innovation.
Excellent. Thank you all to the previous speakers. This has been a fabulous session, and I'm excited to be able to present our work on understanding the policy and finance decisions associated with next-gen sequencing. Here are my disclosures. The recent CF guidelines, which have gotten a lot of attention today, recommend changes in CFTR panel testing that necessitate sequencing and also necessitate additional thoughts about how do we pay for this. As we all know, public health resources are continually stretched thin and become thinner and thinner, and identification of opportunities for cost savings, thank you, is really crucial. It was actually at this meeting last year that my co-author, Dr. Belinsky, said, hey, Marcy, do states pay for sweat testing out of the public health newborn screening program following a positive newborn screen? And if so, and they reduce the number of sweat tests because they only call out infants with one variant, or they call infants with one variant out as carriers and don't sweat test them, could those monies be shifted? And I said, I don't know how frequent that practice is. Let's look into it, which led to our objective to evaluate the newborn screening program policies and payments for sweat tests following out-of-range results, and could there be some cost saving for next-gen sequencing? So this survey looks familiar. We tagged on to Clement's survey and did the same survey, so I won't go through those results on the left side. Further, we interviewed a subset of public health experts and CF clinicians to understand more about the costs associated with their programs, and use that information that we gathered to create a couple of scenarios to demonstrate opportunities for cost savings. I want to say these are a couple of scenarios. These are not all inclusive, and they may or may not fit your particular state, but it gives you an idea of how you might want to be thinking about this. So first, to answer Dr. Belinsky's question, can states divert funding from sweat tests to support CFTR sequencing? 44 states said they just bill sweat testing to Medicaid or insurance. That's very common. But there were 7 states who said, well, we have some other funds. So in those 7 states, what could we do? Of those 7, 2 said sweat tests are covered by the State Department of Health or patient assistance funds. They cover it in its entirety. So those 2 states, if they decided not to sweat test the infants with one variant, could potentially divert those funds and help to pay for sequencing. The other 5 said, first we bill insurance or Medicaid, and then other funds are available. So there still might be a budget there that could be diverted if they decided not to sweat those one variant babies, one variant infants. Yeah, you know what I'm saying. So then we said, well, what are the other costs associated with this? And we get this a lot. I will say right now, this is not a comprehensive economic analysis. This is an interview of a few state newborn screening programs to get an idea, both small states, but large states. DNA testing in-house, running about 39 to 70 variants. The reported costs for panel testing ranged from $50 to $200 per sample. There's lots of variables that impact that. They're listed here. The biggest one really is the number of samples. How many samples do you run on a plate per assay? That really impacts the cost. If you're in a bigger state, it's less because you have more going through on that given plate. Next-gen sequencing, if done in-house, the cheapest I found was $75, and it ranges up to closer to $200 done in-house for a state. Commercial labs may be more expensive than that, and there are other costs that need to be considered and factored in. There is CFTR2 panel testing, which has been mentioned quite a bit as outsourced to Wisconsin. We have 2 genetic resource centers now. Wisconsin and the state of New York are also doing this. I'll talk about this more at the end of my presentation, but they're doing it for about $100. So this is actually quite a deal. Other cost assumptions. I asked CF centers, hey, how much does it cost for sweat tests? And this is about the hardest number to actually get your hands on. We had reported sweat test costs ranging from $50 to $600 in the 5 states that reported it. However, even in 2 clinicians from the same center had different answers. So I picked a number in the middle of those and said, we're going to say it costs about $350 to put into my scenario assumptions that I'll show you in just a minute. Then the follow-up cost per infant. From the newborn screening program side, once a one variant result is sent out, that newborn screening program typically will follow that and make sure that infant's results for a sweat test get back to the state and the case gets closed. In doing so, that takes a lot of time. And the one variant infants, we've heard a lot about that. It can be hard to find them. The pediatricians, where do they come from? All of those things takes a lot of time. Talking to a few of the follow-up coordinators, they said, I don't know, maybe about 2 hours per infant. Some are fast, some are a lot longer. So we averaged that out and came up with about $100 per infant that would cost them to follow that and make sure that infant gets closed out on the public health lab side. Now each state has their different models and it might be different for your state. Other assumptions, based on the literature and other data that we had, we assume that following a positive IRT and a standard variant panel, about 5.5% of infants have one variant and 0.5% will have 2 variants. And the purpose of this, we're going to assume a 96% IRT cutoff. And I will state that genetic counseling is crucial for all scenarios. And I hate that the one patient that Mel just presented did not get their results disclosed, and I think that should never be the case. Even if you're not calling them out for sweat tests, those results need to be disclosed, and that child needs to get sweat tests or get genetic counseling. However, my scenarios don't reflect costs of genetic counseling. So there's that. So scenario one. This is in a large state with a standard CF newborn screening panel. It's going to say 39 to 60 variants. In this large state, they had 100,000 births in a year. Of those, 4,000 go on to have an elevated IRT. Most of them have 0 variants. 220 have 1 variant, and 2 go on to have 2 variants. All of those 1 and 2 variant infants are sweat tested for 240 sweat tests happening, resulting in about 25 infants with CF and 215 carriers. Now, if you're doing a variant panel in-house, typically they run, I'm going to say about $85. That was the estimate I used, and this is actually data from a couple of large states in about this size, that this is a good reflection of what that might actually cost. The sweat test costs, if they were done and billed to the state public health lab, the sweat test costs would be about $84,000, and the follow-up costs of carriers would be about $21,000. Now the state said, hey, I want to switch to CFTR2 variant panel because I read those guidelines and that's what we would like to do. So they did that. They have approximately 1,000 variants, and there's some reasons why it's approximately 1,000, and it gets to the question that was brought up earlier. But the IRT again is elevated in about 4,000 infants. We'd anticipate about more infants would go on to have 2 variants because we have a large panel. Most of the babies would have 2 variants. And we even in this case picked up another baby that wasn't detected in the previous scenario. Infants have 2 variants. Those infants are the only ones who are sweat tested, and luckily for us, they are all confirmed to have CF. The infants with 1 variant, 219 of them, they're reported as carriers. And in this case, in this state, they are not going to be sweat tested. They will be referred for genetic counseling. So if we did the CFTR panel in-house, CFTR2 panel in-house, let's say they did the 139 variant panel, they unmasked the variant call files, which is a service that's available with help from the Wisconsin State Lab as well, it ends up being about $140 per sample. Sweat test costs then are decreased to be about $9,100, and the carry-up follow-up costs now are eliminated. There are no follow-up costs associated with carriers because they're just going on for genetic counseling. So you want to say, well, what's the comparison there, Marcy? Well, it is more expensive to do the genetic sequencing. 340,000 in the variant panel before. In this state, it would be about 560,000 after, which is $220,000 more. If you are a state who could cut costs from doing the sweat tests on those infants with 1 variant, you could save $75,000. However, this isn't a savings most states can really realize. The carrier follow-up costs, that's eliminated. You could save another $21,000, except that's harder to actually shift because that's usually part of an FTE. So those monies could be said to say, well, now you're not going to do as much CF follow-up. Maybe you could shift to SMA follow-up, for example. But now we get to a smaller state. This is more of an average size state with 50,000 births. So in this state, they have 2,000 elevated IRTs, 1 variant is 110, 2 variants is 10. This is again with a standard panel of 39 to 60 variants. 120 babies go on for sweat test, resulting in 13 with CF and 107 carriers. These are data from a real state. This is pretty close approximation to the data. And the assay's $150,000 to do this assay, but labor is very expensive because in a smaller state, you're not running as many infants samples through those panels. So it ends up being about $175 per sample for this variant test in this state. The sweat test costs end up, if again you're a state who pays for sweat tests, about $47,000, and the carrier follow-up costs are $10,750. But now this average size state says, I want to implement next-gen sequencing. How could I do it? So they have elevated IRT, getting used to this pattern now. We're having 109 infants identified with 1 variant. They go on for sweat testing, go on for genetic counseling, not sweat testing. These 2 variant infants go on for sweat testing and are all confirmed with CF. How did they afford to do it? They used a CFTR2 panel test via the genetic resource centers. one of whom is Wisconsin, who has been talked about quite a bit today. The other one of these genetic resources centers is in New York. These run at about $100 per sample. This is quite the deal, right? And so the sweat test costs, again, those would be decreased, and the carrier follow-up costs would also decrease. So what's the comparison here? For this particular state, they would actually save $150,000 by switching from the variant panel in-house to going to one of the genetic resource centers. They could have further savings by, if they're one of the states who covers sweat tests, and by shifting those carrier follow-up costs. So these are not all-inclusive examples that cover everything that every state does, but when you dig into it, it might be that by using a genetic resource center or using other resources, you could actually save money because of the ability of us to work together and send more specimens through, and also make this more timely because these genetic resource centers run specimens 4 or 5 times per week. So are there other places to save money? When we did our survey, we also asked, hey, as CF centers, do you get money from the state to help you track infants with CF newborn screening positive results, to close out the cases, to get the results back to the newborn screening programs? 15 of you said, yes, we do receive funding for that. If fewer carriers are coming your way, if there's less of a burden on your centers, might you be able to offer? So this is looking at you all in this room to say, could you offer some savings back to the state and say, hey, you could decrease our contract a little bit if we're not going to be following up all these carriers, doing all these sweat tests and having to close them out, might we be able to save some money? That's a possibility. What other cost-saving practices are being considered? You could start with a smaller panel and then sequence a subset. That's being experimented with in a couple of states. Sharing resources with other labs. If you don't want to go to a genetic resource center and say, we really want to do it in-house, could you partner with other states to make it more affordable because you're running more sequencing within your state? Within a Department of Health, there's actually one state, Colorado, who's using other genetic resourcing sequencing resources in-house to partner with to decrease those costs. And then the genetic resource centers that I've talked about. You could also alter the frequency of panel testing to do it, instead of 3 times a week, do it twice a week. I do caution you, though, that the guidelines do suggest that we all do it at least twice a week. So decreasing that too much also has a big impact on timeliness. So what do we know from state programs? Here's what we currently know, that 17 are currently using some sort of state sequencing technology. And if I were to present this presentation next month, that number would have gone up, because I know of several of you in this room who are saying, hey, we're just about to send to, we're just about to do this in-house, etc. But changes in algorithms likely require legislative approval, Board of Health approval, other approvals in the state, and increases in fees. It's not just that a state can shift things. And if you're sending out to another lab, as we've seen in the experience with Ohio, it takes some time to get all of those contracts and components in place. So, genetic resource centers, I encourage you to grab this QR code in the upper right corner. These are funded in part, the infrastructure is funded in part by the Cystic Fibrosis Foundation. And these 2 labs have agreed to take in samples from other states, much like we've heard about the successes that came from the Wisconsin lab. New York is primed and ready to do it as well. They have the capacity to be able to run this for many, many states. They are ready to do it. And so this is, you have the leaders in the world, really, in CF genetic testing for newborns, ready to help you in your states to do this. And they're doing it for around $100 per specimen. So this is a really great resource. So if you have questions about this, you can talk to me. Denise Kay is here at this conference, and you can talk to May Baker or someone else from the Wisconsin Newborn Screening Program as well. They can do your CFTR2 panel testing, reporting of variants of varying clinical consequence, and offer technical assistance, both for if you want to do genetic testing in-house with sequencing, or if you want to just unblind some of those variants, you can do that as well with the variant 139 panel. And finally, I'd like to just bring your attention to the toolkit developed by the CF Foundation. This is a great resource to help you all advocate for changes in your newborn screening program. So please grab this QR code as well. I love seeing all the phones going up. This is great. Really just a shout out to Leslie Powell and her team at the CF Foundation who led this effort. So in conclusion, State costs and budgets are unique. The scenarios I put up here are not specific to your state. They are unique and need to be treated as such, and you need to have good conversations. Sequencing is expensive, but there are ways around to save money in-house. If you have decided not to call out those one variant babies, there are some solutions here, and genetic resource centers may provide an economical approach in really many, and actually maybe most programs, to tell you the truth. So I'd like to thank the survey and interview participants, many are in the room, and the Cystic Fibrosis Foundation for their continued support of moving this mission for newborn screening forward. Thank you all for your attention.
Deanna, you want to get us started?
Sure. Deanna Green, Florida. My only caution is in the statement of moving some of the funds coming from the state to the center. In doing many of these things, moving to sequencing, you will have those 2 variants. Many more will be found to have CRMS. And quite honestly, that is much more labor intensive than 2 known variants of CF and even a carrier. And so I would really challenge, do not ask people to move money, giving it to other disorders or otherwise. You need it for CRMS.
I think that's a great point. And I would also say, in response to that CRMS can be tempered if you're not calling out the VVCCs, right? And so how you choose to make your panel, and Florida does call out those VVCCs, so they do have more CRMS, and that is more of a burden. Yeah.
Hi, I'm Sameda, genetic counselor from Wisconsin, and I think that we have a great algorithm, and probably other states are using this too, to try to balance out how many VVCCs, or how many kiddos with CRMS or CF SPID we're getting. So as you guys probably know, we have a high IRT with a static failsafe, and then use the CFTR2 panel to look for CF causing variants. If there are 2 or 1, then that is flagged as a positive CF newborn screen. And then depending on if there's 2 or 1, those kiddos will go either straight to the CF center or get slotted to a sweat test. Once the genetic counselor meets with the families at the time of the sweat test, then if there is a borderline or elevated sweat test, which is what one of the speakers was mentioning, then we contact the state lab and ask them to unblind the complete CFTR sequence, including VVCCs. So what you're doing is you're avoiding the children that might have either 1 VVCC or 2 VVCCs with no clinical marker that's concerning for CF. So now the only kids that you're picking up with a VVCC are the ones that are clinically relevant. So that is a way to minimize your kiddos that have just 1 VVCC or 2 VVCCs.
I think that's a great point, and I think that's a beautiful demonstration of how you're doing it in Wisconsin. Thank you so much. Dr. Farrell.
Thank you very much, Marcy. I like your calculations. I wanted to make a comment and ask a question. The comment is this. Next generation sequencing is likely to become less expensive in the future. There's opportunities for automating the analysis, just has been done for whole genome sequencing, automating the DNA extraction. So I think it's going to wind up being less than $100 eventually. And here's the question. Have you calculated, since you're really into calculations, I admire that, have you calculated the probability of a false negative due to IRT compared to a missed case from CFTR2 next generation sequencing test? I suspect it's going to be higher on the IRT side.
I suspect you are likely right as well, although I think that's going to also depend on the state that you're in. Because I think there's some states who have incredible diversity, and it still might be a challenge to identify all of the children without a very high IRT cutoff as well, which is why in the guidelines, as you know, we ended up with that very high IRT, because if you have a very diverse state, it might be harder to pick those up. So we would have to do that probability calculation across different scenarios of states and their genetic makeup, I believe.
I think we have one question in the app on for sending samples to a lab out of state for sequencing. What is the turnaround time for results and the added cost for shipping?
It's a good question, and I think, and I'm looking to some of the states in the front row who are having this, it's less than 7 days. Does that sound right? I'm getting yes, very affirmative yeses. So it's a quick turnaround time, and in many cases it can be faster than what you can do in-house because they're running it 4 or 5 times a week, right? So you send it out, they're running it versus you running it in-house just once a week. So,
and the shipping costs are probably minimal.
Yeah, I'm not sure. I did not include shipping costs here, so I can't comment to the cost of shipping.
And one last follow-up, and then we'll finish up. Is there a cost for unblinding the full sequencing data if someone has an intermediate sweat test?
There's no cost for that, at least in the Wisconsin program from what I've talking to Maybaker about. That's part of their service. Do you want to close it? Okay. So thank you all, the standing few who stayed for the whole last question. Thank you so much. We appreciate your dedication to CF newborn screening, and we look forward to seeing you later in the conference. Thank you all.